We're now going to be talking about the different patterns of ST elevation and the localization of the culprit artery in a myocardial infarction. Occlusion of the LAD, the left anterior descending artery, is going to cause ST elevation in the anterior leads, which are V1 through to V4. You'll usually find reciprocal changes in the inferior leads in an anterior infarction. The number of leads involved is important because it can associate with the degree of ischemia and therefore the degree of myocardium at risk. Now, looking at the anatomy, you can see that the branches of the LAD include the septal perforators and then the diagonal branches. The septal perforators will supply the septum, and the diagonal branches will go to the anterolateral wall. If the occlusion is proximal to the first septal perforator and the first diagonal, then there'll typically be ST elevation in the anterior leads and also the lateral leads as well, representing ischemia from the lateral wall. So this will be V5, V6, AVL, and lead 1. That's because the diagonal goes to this anterolateral wall. In the case of a proximal LAD occlusion, we'll typically see reciprocal changes in the inferior leads. So a proximal occlusion, as you can imagine, will put more myocardium at risk in comparison with an occlusion more distal of the LAD. Other things to note are that this type of MI may cause a right bundle branch block, and this is due to ischemia in the septal perforators territory, which supplies the right bundle. The left anterior fascicle is also supplied by this artery, and similarly, it can present either by itself or quite often in conjunction with a right bundle branch block. Alternatively, you can have a distal occlusion of the LAD, meaning distal to the first diagonal, and this will likely produce ST elevation from V3 to V5 with an absence of lateral lead ST elevation. There are other possibilities, and the patient can have variable anatomy. Terminology you'll often hear is a right dominant system, a left dominant system, and also a type 3 or wraparound LAD artery. And so this is when the patient's anatomy is such that the LAD wraps around to supply not only the apex of the heart, but also the inferior wall. And that's when it's called a type 3 or a wraparound LAD. When you have occlusion of this type of LAD, it can mean that you'll find concomitant ST elevation in both the anterior leads and also the inferior leads as well. And again, this is going to put a large amount of myocardium at risk.